I was asked to talk about reaching adolescent girls and boys with healthcare. What's new, what's different, what's working? And I work with UNICEF for many years, so if I pick some examples and not others, I would be asked, why are you talking about this organization and why not that? So what I'm going to do today is I want to share with you 2 or 3 key data points to help advance the conversation. Then I'll pick some examples, but I've organized them around some of the work where I have personally experience with in the Tanzanian context. And then I'll branch out. I'll give you some broader picture around common good practices of what we found in working with adolescents on healthcare. And then I will leave you with a few takeaway messages. Going forward, yesterday Professor Rees presented you some of the data, and it's no news about the adolescent, the youth bulge on the African continent. But what we must all look at is what's happening in each country. This is a UNICEF report published in 2014, and it's just a couple of countries, but to just show you the variation of what's going on in this part of the world. The green line is Tanzania, the country where I live and work, and we have currently about 12 million adolescents 10 to 19 years. In the next 33 years, this is going to more than double. The country will have 27.5 million adolescents in that age bracket. The yellow line is Uganda. It's going through a similar growth spurt. The blue line is Kenya. Then interestingly, South Africa is the gray line, and it's from 2015 up to 2050, sorry. South Africa is going through a different development. Your adolescent population isn't going to double. You're going to, unless something else happens, but your adolescent population is going to flatline and slightly decrease. And there will be variety of reasons contributing to that. Zambia is also going to increase. And interestingly enough, Zimbabwe, it's going to flatline. In a month's time, a new report will be issued, and it'll be important to look out for that. The next key piece of data I wanted to share, and it's not news for you and for anyone in this room, that most of the adolescents are living in Africa, but you've got to look at where are they, in which country. And I just wanted to re-emphasize that nearly 70% of all adolescents globally are in this part of the world. So henceforth, solutions and strategies on what's working, what's not working, and at what cost will come from these countries. In terms of reaching adolescent boys and girls with healthcare, communication approaches have been widely used. Behavior change, social change, policy advocacy, different kind of communication approaches. And what we found in UNICEF useful is to structure our thinking around a socio-ecological model. It's a bit of a crowded table, but there are 4 areas. And one is the typical one, where many interventions work at the individual and the interpersonal level. And here I just want to point out that level continues to be critically important. And I wanted to clarify the power of interpersonal communication and counseling and correct some misunderstanding around peer education. We've seen some articles suggesting that peer education doesn't work. But we're also seeing articles and evidence that if peer education done well and combined with additional intervention, it has shown really great success. And thirdly, around the interpersonal and individual level, the importance of schools. You spoke about it yesterday. It's hard for health professionals to reach into the educational system, but that's the future, and the foundation is laid already. School health, most children in our region, 10 to 14, are in primary schools. So that's where traction needs to happen as well. The second level is around community, and I'm not going to go through the objectives, but what I wanted to say is that what we found that many community-based interventions, they generate energy, they generate interest, and they may do good things, but many of them lack a clear theory of change. They are also not clearly articulating what are these components what are the elements around what communities are being mobilized with. So those two aspects are important when we want to go to scale. What's the theory of change? What are we trying to change with the community? And what are the critical core components? We've heard yesterday from in the opening about the successful program in Zimbabwe about using community-based treatment adherence supporters. So where you have a much more engaging and involving community-based approach, we do see good success. The third level, and where we see perhaps less action, some, but where we may need to see more, is around organizational, institutional change. And communication efforts are really important there as well. We've seen a good number of training efforts with health workers, but they're often in service, they are not necessarily standardized, and they haven't made it into pre-service and really, being rolled out into generating a substantive mass of skilled health workers. And from the experience in Tanzania as well as in Kenya, I was in Kenya 4 years before I joined Tanzania, is, not every health worker needs to be trained on everything, but yet our training manuals suggest that. They're often very complex, convoluted, and difficult to implement for a Ministry of Health. The last area, just in terms of our thinking around communication approaches, is policy and the enabling environment. We've seen some really fantastic examples from South Africa, the Treatment Action Campaign cited everywhere for years, but we're not seeing enough new evidence or results where policies and the enabling environment has been substantially improved. Laws, regulations, guidelines, protocols in a country are critically important. Now, this is data from a new tool my colleagues at headquarters have developed. It's a data visualizer which shows trend over time for a couple of key indicators on government-approved data. So we've been given permission to use this tool, and it's available for all our countries in this region. What this tool does, it shows, for example, I've only picked one indicator. This is trends in the HIV-positive population. It starts from under 1 and it goes up to 24, but it's disaggregated in smaller, more nuanced age bands. For us, I wanted to point out, so anyway, and it's going back 2000 to 2016, which is when the most recent HIV estimates are available. So the green line is ages 20 to 24. And this is only Tanzania, and one needs to see what is the case for other countries. But for Tanzania, we're seeing good progress about a decline in HIV-positive 20 to 24-year-olds. It's probably the success of the PMTCT program. I'm speculating, but what I wanted to bring to your attention is the dark blue and the yellow line. Dark blue is 15 to 19, and yellow is 10 to 14. So what you see here, and what we know for the country where I am working, and again, you need to look at what your country's data is saying, but what I can see for us is that the 15 to 19, we're not seeing change. Yeah, the adolescent population with HIV is hovering around the same area and slightly increasing. And the adolescent population 10 to 14 is increasing. So that's as such not news, but what it's important is about we have the numbers associated with this. So our treatment and care programs need to be geared up to be able to serve this population where they are. Now, in terms of UNICEF's work, and I can really only speak here about my own work we're doing in Tanzania, it's, and again, using the same kind of hierarchical thinking around working at the policy and the enabling environment. Tanzania, like many other countries, South Africa is in a different situation, I guess, but you have to have standards of care in place. And for your health workers, there needs to be some protocol around what health workers need to be trained on. It's a new emerging area, but it needs to be rapidly put in place. And much more importantly, these standards and what was being implemented needs to be monitored and continuously supported, because it's not going to happen overnight. The biggest challenge for us in Tanzania is the implementation of these training manuals. There's no absence of guidance, but the implementation and how do you roll it out in a country which has 1.3, 1.4 million people living with HIV. At the organizational level, an example I wanted to share with you, some work around capacity building and scaling up of psychosocial support, treatment support, and also importantly, protection of adolescents living with HIV. We see increasing reports around violence, issues, which are going beyond the treatment agenda, but a more holistic type of approach. And what we are trying out is a new model with different NGO partners, including with the Baylor College of Medicine, PASADA, and other NGO partners, is to really, in a very short period of time, try to build capacity of public health government workers. So a twinning type of approach where NGO, seasoned, experienced staff are providing expert advice and coaching and guidance on the job to outside NGO settings. In November, next month, we'll have a big meeting to review the progress and is this approach useful and are we making a difference? At the community and the support group level, I wanted to share with you an exciting example. We know in many of our countries, we've seen teen clubs flourishing in health facilities. In Tanzania, pretty much every care and treatment site is trying to do a teen club now. So that means when the young person comes, when drugs are being collected, there's a bit of psychosocial counseling, but we don't really know up to which standard that is, and activities around it, but it's facility-based. So we've been working with our NGO partners to see how can we take what's happening in the teen clubs facility-based outside to the communities. And these teen clubs have become the center of attention, the ambit. They are every teen club is associated with what the group called Teen 10 Cells. I don't know why cells, but anyway, that's what the young people chose. The TTCs are community-based. So the teen club is the mother network of the TTCs. And the TTCs are community-based. And they're not, they're small. They're up to 10 adolescents living with HIV who come together and are supported. They are discussing issues around treatment adherence, but also much more broadly what's going on. And they are supported, importantly, by an adult supervisor. There's a pointer on the slide I wanted to also bring to your attention is these Teen 10 cell leaders. They're the ones who are a bit more empowered, more confident, and they're also the ones who are engaging with local government, with the community leaders and with the ward officials, which is the lowest level of government there. So I want to change gear now and get your attention on another exciting entry point for health professionals. And that's the angle of social protection. We've spoken yesterday about poverty-driven diseases, and you have in many countries in this region fairly large social protection platforms, social cash transfer programs. Tanzania has a very large social cash transfer program reaching 1.1 million households. And what we've designed with the government together and our partners is what we call Cash Plus. It builds on the evidence coming from South Africa, from Zambia, from Malawi, where everyone has noticed the beneficial outcomes of cash transfer programs. But we've also, in the Tanzanian context, realized that the cash does not address non-financial barriers to improve SRH or HIV outcomes. Meaning if the supply side is still full of barriers, the cash transfer is only getting you so far. So it's fully embedded in the Tanzania, it's been implemented through the government structures. And the cash transfer program in Tanzania is a poverty-targeted program. So it doesn't have anything in particular around adolescents in those households. And the added value UNICEF has brought, I hope we've brought to the table, is to develop and tailor interventions for 14 to 19-year-olds adolescents who are in these households or who are already the heads of those households. Because by age 19 in Tanzania, 60% are already pregnant or have a child. So you got to speak to the realities in those households. It's 2 years, and as I said, the plus component is largely composed of 3 levels of interventions. One is livelihoods and an economic empowerment training and coaching. The second one is education and training around sexual reproductive health, HIV, gender norms, and violence prevention. And the third one is to facilitate access to services, in particular health services in the local community. This is the map of Tanzania. It's a huge country. We are doing this in 2 districts because we all want to learn how we're doing this. And again, it's very segmented, it's very tailored to be able to run on a social protection platform. The Ministry of Health is very closely involved as well in terms of validating and agreeing on the training manuals. And what you might find interesting, it's implemented through the local government workers. So in Tanzania, there are very many community health workers and community development workers. They're there already, and they're not paid well, but they are part of the official government cadre. So this will be accompanied with a training, and it's going on right now, a training of a critical mass of youth peer educators who will be then teamed up with the local government officials to then enroll and train over a 12-week period 2,500 adolescents. And again, adolescents 14 to 19. The training is staggered over 12 weeks. And 12 weeks because the practitioners on the ground were saying you can't do this in a 6-day training and block training. These kids from these households have very particular circumstances. So we're trying out once a week, 4 hours over 12 weeks. And what gives doing so gives you the opportunity to build an experiential learning so that when you have the training, the adolescents can do some assignments, something to find out about their local community and come back with a suggestion or come back with a problem which is beyond their own ability to solve. But that's then when they have the mentors and the local government officials to help them. Lastly, about this Cash Plus program, it has a very strong theory of change, so that, I don't know strong, but we do have a theory of change, so that we will learn what's working and what's not working, and that we are able in 2 years' time, and maybe earlier, to see this is not what's working, and let's adjust here or there. And it has a randomized control trial accompanied to it, because if it goes to scale, government will only want very solid evidence to inform their decisions. Now, in terms of general good practices, we heard about this a lot yesterday, but I did wanted to make the case again, and I think here really the opportunities for the private sector, NGOs, and the research community to come up with very well segmented approaches. Many of the public health approaches to adolescents, healthcare in general, are still pretty broad-based. They're not segmenting very well. And we've heard yesterday very good examples around tailoring to adolescents in very special circumstances. I did want to make a point about boys. We keep saying we need to differentiate, but what I have seen in terms of implementation, it's very often the same type of implementation we do for girls as for boys, and some projects, they segregate the groups, so they do something for the girls and something else for the boys. But you've got to speak to the needs of boys as well, and very quickly so, because in Tanzania, HIV testing and treatment, boys have much poorer outcomes. But we have a significant amount of funding available right now for adolescent girls and young women. This is good and it must continue. We must have funding for girls and women as well. But while we're doing that, we have to also be able to utilize these great opportunities to find solutions which work for boys and in their different ages. The second point I wanted to make is around equity. The programs which are matrix obsessed, which are obsessed with meeting high targets, are not necessarily equity-based. It's hard to do that to get your numbers because you will go to high volume facilities where you can find more adolescents living with HIV. But if you were to go to adolescents who are not linked to facilities, that's more difficult. And linked to that is also, we found, and I think just in UNICEF, but also the global evidence shows that most programs tend to be better at capturing elite adolescents. And elite in a way, those who are better off from higher wealth quintiles. And for sure, they have equal needs around treatment and care, but the additional type of support adolescents who come from lower wealth quintiles or not in education system often falls through the cracks. Thirdly, strengthening community-based platforms. Improving adolescent HIV treatment and care, as well as their overall health, has largely focused on health facility-based interventions. And we have good experience around what's working in communities and how do we strengthen community-based platforms. And I'm saying platforms because I mean not just interventions. It's not just come to a community, deliver an intervention and go back, but work with local community leaders who are there and who are staying there to create safe spaces and spaces where different segments of adolescents can come together and they can gain agency, they can participate, they can do so much more than just HIV. Another good practice is the importance of the walkable community. Walkable meaning adolescents, especially 10 to 14, both boys and girls. We've heard yesterday about the issues to go to the facility to get your treatment. So, if we come with our interventions and it's not close by, in walking distance, especially 10 to 14-year-olds who are either in school or at home or doing household chores, they're not going to benefit or be able to participate in programs we offer. And walkable community also mean start investing in building capacity in community leaders, in people. Yesterday there were good examples around the importance of teachers who are there, who live there, the local health worker, or your local religious leader or someone else who's influential and inclined, to support adolescents. So it's not just about the geographical space, but also the people and the resources available in those local communities. Then I wanted to make the point about societal assets. The global community has been talking about involving adolescents. We've been talking along for involving young people. Professor Rees, if you remember, that was involve young people. That was some 10 years ago. Now we're talking about involving adolescents. But here, really, you got to pay attention. We all collectively have to pay attention to the 10 to 14-year-old. And it doesn't mean we need to invite 10 to 14-year-olds to conferences like this. But it means making partnerships, putting programs and mechanisms in place where younger ones have an opportunity to participate as well. The next point is around working across sectors. I think we have very good experience suggesting that multi-sector type of approaches are very useful. What we don't know is how to do it. And the suggestion is, instead of trying to create parallel new structures, to trying to coordinate very complex new programs, you cut into the sectors and you make a dent in the sectors. So that means working with your education system, again, really, really important opportunity, your social protection partners, urban planning, and I also wanted to add the importance about criminal justice. Where you have perpetrators of violence, what's going to happen to them. So lastly, really important, whatever we do around adolescent health, whether that's HIV treatment and care or broader adolescent health agenda, it's about have always scale in mind. When you design programs, how is a government going to scale up what we're trying to do? And not everything can go to scale, but then let's document what's working and what's not working and have a collective knowledge base around that. And what is the impact in the sustainability? Currently, we have more funding than ever available to all countries to improve adolescent health. So it's a really strategic opportunity. Briefly, if you're looking for global guidance, it has been issued. WHO, UNICEF, UNAIDS, the Bank, others have issued earlier this year what is called the AHA guidance. If you don't remember anything, remember AHA. Okay? Aha. It's around accelerated action for yeah, okay, it's up there, but anyway, but it's really important guidance notes. So, the global agencies have issued these guidance notes. They are for countries' considerations. They are the new milestones for countries to work towards too. And really, I mean, it's a long document, but do look at it. And what's most important about it, it's a paradigm shift on how global agencies are looking at adolescent health from multiple angles. Aha, okay. So in conclusion, I wanted to share a few takeaway messages, if you allow. I do want to reiterate the importance of disaggregated data. And we've done very well in HIV. We've not done well around sexual reproductive health or other types of health data to really crunch down the numbers and granulate as much as you can. The second one is different and complementary platforms. Start looking outside the health sector for solutions to improve adolescent health. Implementation research. I know there's exciting research in the pipeline, but we need more of that. So funders and supporters and coalitions of researchers in the room, we know, I think the global community has a pretty good idea also at country level of the issues, but what we need to know now is which interventions are working, under which conditions, for whom, and at what cost. Governments we need to enter into this new area of costing to help make our government colleagues informed choices. And lastly, is the language around adolescent programming. For long, we've been speaking about problems, disease, it's too complex, sexuality, sensitive. I think collectively, if we can have a critical mass to talk about the assets, the positive spin-offs, and what I also think many of our governments we're working with, they talk economics. If we can venture into that area about the economic development and the social development, would be a good one. Clearly, adolescents living with HIV, clearly, they continue to require specialized treatment and care. And we have to do better at how we're going to deliver it, at what cost. But HIV and SRH, they were and they are important entry points to improve overall adolescent health. And it is for us and others to now push the agenda forward, because now you can do it in its own right. That you have the SDGs, Lucy spoke about them yesterday, and I wanted to reiterate the point because they may not mean much to us individually, but globally the sustainable development goals, and our countries have signed up for them. So this is the new accountability framework in which results will be measured. And the better we integrate into that and leverage it to move adolescent health forward in its own right. So you don't have to go and beg anymore, like if you want to do an additional intervention, the better. And lastly, I wanted to say the issue around the triple dividend. It sounds a bit like jargon, but it's really hits home. When I started, it was about the future, youth development, so we have a better future. But really investing in adolescents, especially in the young ones today, is going to give you benefits immediately and in the near future and in the long future. Because if we miss the second window of opportunity in a child's life, we've made a major mistake. So I wanted to thank you all very much, and I wanted to acknowledge also my many colleagues who helped me to put this together, my own office, our regional office, and also our government partners who we have very strong collaboration with in Tanzania, the Ministry of Health, the Tanzania Commission for AIDS, and our very different NGO partners on the ground. I thank you very much, and if you would like any other information, I'm here, or if you want to send an email, I'd be happy to answer. Thank you.
Thank you.